I'd like to welcome the reader to the chapter on spinal cord stimulation. I'm Orrin Sager, and together with Dr. Emily Levin, we're pleased to provide you with a synopsis of the history, the mechanisms, and some of the clinical data underlying electrical stimulation of the nervous system. This PowerPoint presentation is intended to provide you with an overview of the contents of the chapter. It is not intended to substitute for reading the chapter and some of the key references within it. We hope that listening to this presentation gives you a flavor of the chapter contents and provides you with a frame of reference as you read the chapter itself. To view neurostimulation therapies in historical context, interest in the use of electricity to stimulate the nervous system dates back several thousand years prior to the development of spinal cord stimulation. We know that people were interested in using naturally occurring sources of electricity such as that found in electric rays even as far back as 5,000 years ago in ancient civilizations. However, the ability to create and store electricity was a necessary development before this could be truly harnessed and advanced. The invention of the electrostatic generator and ways to store electricity were a necessary precondition for developing neurostimulation as we know it today. Early enthusiasts of electrotherapy championed the use of electricity even then for the treatment of conditions as disparate as angina and sciatica, even going back to the early 18th century. One of the most important developments in the scientific study of neurostimulation is the gate control theory of pain neurotransmission, proposed by Ron Malzak and Patrick Wall in 1965. This theory, which incidentally is still unproved, postulates the existence of electrical gates in the dorsal aspect of the spinal cord that mediate and modulate sensory input to influence the experience of pain. It took only 2 years after the publication of this theory for a neurosurgeon named Norm Shealy to attempt to put into practice what Malzak and Wall postulated. Norman Shealy applied an electrical current to the spinal cord empirically in order to test whether he could artificially modulate Malzak and Wall's purported gates to influence pain. In one of the more impressively successful bench-to-bedside examples in medicine, the application of electrical current to the spinal cord has proven to be an incredibly useful treatment for chronic pain, even though we're still learning its underlying mechanisms. Today, we face an ever-expanding array of electrode configurations and highly sophisticated generators that includes advanced circuit boards and sensors which allow us to deliver different types of electronic waveforms. The electrodes vary from linear concentric arrays, such as those you see on the left side of this picture, all the way to tightly spaced paddle-type electrodes that provide for directional stimulation of the spinal cord, like you see in the middle of this image. The devices that power these leads are incredibly small and highly sophisticated as well. They deliver any number of waveform patterns and have internal sensors that provide direct closed-loop feedback to patients undergoing treatment. Some of these generators are rechargeable and others are completely internally powered. Much of what we've learned over the last 50 years of using spinal cord stimulation in the clinical setting arises from the observation of patient responses to stimulation. We've learned, for example, that stimulation changes not only with amplitude, but also with frequency and pulse width, as well as the position of the patient. We've also learned that spread of current to the dorsal roots, commonly perceived as an unpleasant experience by the patient, increases with longitudinal stimulation and is diminished when stimulation is performed transversely. Our understanding of current spread and associated paresthesias has also been greatly aided by sophisticated finite element modeling done by electrical engineers like Jan Holzheimer, and illustrated on the left side of this slide. What Holzheimer elegantly showed was that a current field created by transversely positioned anode and cathode allowed for increased penetration of the spinal cord near the midline with a reduced unwanted lateral spread. This has greatly facilitated our ability to expand the therapeutic window of stimulation for patients. It's also informed our operative strategy in terms of segmental positioning of the electrode in the spinal column. While our chapter also goes into some of the neurohumoral aspects of spinal cord stimulation, it's outside the scope of the brief PowerPoint presentation, and the reader is encouraged to delve into some of the studies of non-electrical mechanisms of spinal cord stimulation. The studies described in this chapter, along with others, suggest that the mechanisms underlying spinal cord stimulation are far more complex than those mechanisms that spurred its development in the first place. While there is much we don't understand about spinal cord stimulation and other forms of electrical neurostimulation, we've been able to define a set of patients and associated conditions where this therapy is especially useful. Pain conditions arising from neural injury appear to be particularly sensitive to neurostimulation, and today, chronic radiculopathy, painful neuropathy, and complex regional pain syndromes are all conditions that routinely lead to application of this treatment modality. The last 10 to 20 years has also seen the publication of several important surgical studies examining the value of stimulation in a treatment of chronic back pain. I would like to highlight two of these studies in this presentation. The first is an often quoted study by Rick North that examined a series of patients with recurrent symptoms after back surgery. These patients were all candidates for reoperation and were randomized to either repeat surgery or spinal cord stimulation in a clever design that utilized voluntary crossover rates as a primary outcome measure. North found that the patients who were randomized to the reoperation group crossed over to stimulation at a much higher rate than those randomized to stimulation primarily. A comparison of spinal cord stimulation to conservative management was subsequently done on a large scale by Kumar in a now famous PROCESS trial. In this randomized controlled trial of spinal cord stimulation conservative management, Kumar found that pain relief rates were better with stimulation than they were with optimized conservative treatment, both in the primary assignment and in voluntary crossover groups. One of the more interesting aspects of spinal cord stimulation is its effect on vascular tone. This was initially an empiric observation on a single patient who had ischemic pain and in whom spinal cord stimulation not only relieved pain but also improved tissue perfusion. This observation spurred significant basic science and clinical investigation that led to the development of neurostimulation for the treatment of peripheral and more recently cardiac ischemia. These indications, while not FDA approved, are extremely common in Europe and hold promise for the treatment of patients with small vessel disease. There have been a number of developments in the technology of spinal cord stimulation that have led to improvements in treatment over the last several years. Among these is high-frequency stimulation, which is usually defined as stimulation frequencies greater than 1,000 Hertz. Engineering advances over the last several years have allowed the creation of circuits that deliver extremely high frequencies of stimulation. While this stimulation is free of associated paresthesias due to the high frequency bandwidth, there is evidence mounting now that such high frequencies are still associated with pain relief in patients. The additional advantage of high frequency stimulation is related to the absence of these paresthesias, which frees patients from unwanted stimulations in areas they find unpleasant or unwanted. Investigation into the mechanisms underlying pain relief from high-frequency stimulation is still ongoing, and at the time of this writing, not entirely clear. Another relatively recent innovation is that of burst stimulation, which, unlike high-frequency stimulation, is not tonic in nature. Burst stimulation is defined as short trains of high-frequency stimulation, where each train is repeated at a lower frequency. The rationale behind burst stimulation was that it recapitulates the normal frequency encoding of transmission within the nervous system. However, it's unclear whether this rationale underlies the benefit of this modality. Still, there is accumulating data that burst stimulation offers additional benefit for certain patients when compared to conventional stimulation. The reader is encouraged to review some of the pivotal trials, including the Sunburst trial that was published in 2018. Finally, there is dorsal root ganglion stimulation, which is a bit off topic in as much as it's not officially spinal cord stimulation. However, since dorsal root ganglion stimulation devices are also inserted into the spinal canal, this modality deserves mention here. This treatment was approved by the FDA in 2016 on the basis of a pivotal trial that examined its use in a population of patients with CRIPS and showed that it offered superior results when compared to conventional spinal cord stimulation. Like high-frequency stimulation and burst stimulation, DRG stimulation is also paresthesia-free and allows the clinician to focus stimulation to narrowly defined affected areas. In summary, spinal cord stimulation is a therapy born out of a theory, informed by clinical observation, and advanced by developments in engineering. Current-day stimulation systems consist of tight multi-channel arrays, sophisticated circuitry, rechargeable batteries, and positional feedback. Future directions of this treatment modality include more sophisticated closed-loop systems, activity detection, and even neural activity sensing. This is a very exciting field that allows us to deliver effective treatments for pain while learning about how our nervous system perceives and processes sensory inputs. I hope you found this brief presentation helpful and useful as an introduction to neurostimulation. I would strongly encourage you to deepen your understanding by reading through the chapter and the key references within it. Thank you.